Cardiovascular Drugs lecture. The following are common cardiovascular system diseases you will want to be familiar with: myocardial infarction, cerebrovascular incident, atrial fibrillation, aortic stenosis, mitral stenosis, angina, deep vein thrombosis, hypertension. How drugs affect the heart. There are three different effects. There's the inotropic effect, which increases or decreases muscle contraction. There's the chronotropic effect, which increases or decreases the heart rate. And then there's the domotropic effect, which can increase or decrease the conduction of electrical impulses through the heart muscle. Cardiac drugs, there are several different categories. We have the cardiac glycosides, antiarrhythmic agents, antihypertensive agents, vasodilators, antilipidemic agents, anticoagulants, platelet inhibitors, thrombolytics, and hemopoietic agents. Cardiac glycosides. Digoxin or Lovenox is the medication in this classification. It is in treatment of heart failure and sometimes atrial fibrillation. It increases the force of cardiac contraction, which increases the cardiac output. It increases the systolic contraction, it decreases the heart rate, and increases the muscle tone of the myocardium. It also increases the flow of blood to the kidneys, causing a diuretic effect. Digoxin also decreases pulmonary congestion and lower extremity edema. Therapy must be closely monitored for toxicity. We oftentimes have to do serum blood levels. The range for this is 0.5 to 2.5. And typically when we are drawing these blood levels, it has to be in a red or a gold top tube. You will want to verify with your provider whether they want a trough or a peak level, and this does need to be specified on the lab order. A trough level is where we take the blood serum level before the patient takes the medication for the day. A peak level is about an hour after the patient has taken the medication for the day. We will often want to monitor EKGs and also check pulse rates. Antiarrhythmic agents, we have adenosine, which restores normal sinus rhythm from PSVT by slowing conduction time through the AV node. It also vasodilates, so oftentimes they do use this for stress tests. Not as common anymore. This used to be the mainstream stress test medication agent. It can be given either IV or IM only. We also have beta blockers. In this class we have propranolol or Inderal, metoprolol or Toprol XL, or Carvedilol, also called Coreg. They inhibit the adrenergic nerve receptors, and beta blockers also are used for angina and hypertension. They make the heartbeat slower with less force, therefore they decrease the heart rate and blood pressure. So beta blocker actions. So there are two different types of beta blockers. There's the beta 1 blockers, which affect the heart, and then there's the beta 2 blockers, which affect the lungs. So you have one heart, but you have two lungs. That's how I always keep it straight. Amiodarone treats ventricular arrhythmias. There are many side effects to amiodarone: hyperthyroidism or hypothyroidism, pulmonary fibrosis, hepatitis, neurotoxicity, visual disturbances can all happen with amiodarone. It needs to be closely monitored. Patients need to be tested with a TSH and liver profiles routinely. They will need EKGs to see arrhythmia changes or rhythm changes in the heart. They will need yearly eye exams to know any changes that can cause permanent blindness. And then they also need routine chest x-rays. Generally, we do these routine chest x-rays 1 month after starting the medication, and then every 6 months to a year thereafter to check for any fibrosis that may be occurring due to amiodarone toxicity. Dronedarone, or Multaq, is a treatment for atrial fibrillation. This is more and more replacing the amiodarone. It is used in stable patients as an alternative. It has less side effects and no toxicity. Typically, we are not running any labs or any eye exams or chest x-rays with this medication like amiodarone. However, some physicians are starting to do liver profiles just to double check those liver enzymes when taking this medication. This medication is still brand name, so it is oftentimes more expensive. It is really dependent on the patient's prescription formulary as to how much they will pay for this medication. Calcium channel blockers. The most common are verapamil and diltiazem. They treat atrial fibrillation, PSVT, angina, and hypertension. They slow the AV nodal conduction and they decrease the heart rate. Procainamide is used as an alternative to amiodarone in emergency situations. It is used when ventricular tachycardia is present. They also have severe side effects such as vascular collapse, GI upset, and respiratory arrest, typically only given in the hospital or an ER setting. Propafenone, or Rythmol, treats life-threatening ventricular arrhythmias and converts atrial fibrillation to normal sinus rhythm, usually started in the hospital with monitoring. Other antiarrhythmic drugs are sotalol, also called beta-pace, or delphetalide, also called Niacin. Both medications are started in the hospital by a cardiologist, typically to monitor for any arrhythmias that may occur while the patient is started. Patients should be advised to not stop without consulting a physician. Antihypertensive drugs. So hypertension is not a curable drug, we control it. So once you're put on an antihypertensive, rarely are you taking off of it unless you make lifestyle changes. Some of the important lifestyle changes that patients can make are eating a DASH eating plan, reducing the amount of sodium they eat, no salt added diets are common, increase physical activity, modify alcohol use, and stop smoking. Antihypertensive agents. There are 6 different classes. There are the beta blockers, the calcium channel blockers, angiotensin converting enzyme inhibitors, also called ACE inhibitors, angiotensin receptor blockers, also called ARBS, anti-adrenergic agents, and then peripheral dilators. Our beta blockers, the most common that you will come across are propranolol, atenolol, metoprolol, carvedilol. Those 4 are the most common beta blockers. They will always end in OL. So beta blockers always end in OL. The action that they take, they block the beta receptors. They cause a decrease in heart rate, force of contraction, and decrease the rate of the AV conduction. The most common side effect among beta blockers is a decrease in blood pressure or bradycardia. Also, patients tend to be highly fatigued on these medications. So that is a very common side effect. Side effects of the beta blockers, so hypotension, symptoms of CHF, so the coughing, shortness of breath, edema, and fatigue, bradycardia, which can often be caused by an AV block in the electrical system in the heart, and then drowsiness, and with the drowsiness comes depression. Calcium antagonists are verapamil, nifedipine, and diltiazem are all examples of this medication class. They generally are pretty nice drugs. There are not a lot of side effects that patients will have. They decrease the contractility and decrease the conductivity of the heart. They decrease the demand of oxygen that the heart needs. Side effects are a decrease in blood pressure, bradycardia, may precipitate an AV block in the EKG, headaches, abdominal discomfort, constipation and nausea, and then peripheral edema. For the most part, most cardiac drugs often cause constipation and nausea. So any patient that's on a lot of cardiac type drugs will also be on stool softeners. ACE inhibitors, angiotensin converting enzymes. This is typically one of the first line medications behind our diuretics as far as hypertension treatment. Thiazides are usually the first line treatment in hypertension, which decreases the amount of blood volume, which decreases the amount of cardiac output in the heart, which decreases the blood pressure. But behind our diuretics is the ACE inhibitors. They decrease peripheral vascular resistance without increasing the cardiac output, cardiac rate, or cardiac contractility. So examples of this medication, the most commonly prescribed medication out of this class is lisinopril. You will also see sometimes captopril or enalapril, benzapril. Anything that ends in pril is an ACE inhibitor. Common side effects are dizziness, orthostatic hypotension, GI distress, non-productive cough, and headaches. Oftentimes patients on lisinopril will complain of this non-productive cough. It is important for patients to inform physicians about the non-productive cough, because even after this medication may be changed or stopped for some reason, the patient will continue with this non-productive cough. So it's very important for patients to report that. Angiotensin receptor blockers, or ARBS, block receptors that cause vasoconstriction when stimulated by angiotensin II in the kidneys. The most common medications are the losartan and valsartan. They decrease the blood pressure without changing the heart rate. There are less side effects than the ACE inhibitors. However, patients with any type of renal impairment should not be put on these medications. And oftentimes the ARBs are a little bit more expensive in cost. Therefore, physicians do not go to these medications as a first-line treatment. Antihypertensives, antiadrenergic agents such as clonidine or prazosin can be used to treat antihypertension. These are typically not our first-line treatments. Usually we go to these types of medications when ACE inhibitors and beta blockers and our ARBs are not working. Peripheral vasodilators such as hydralazine, same thing, not a first-line treatment, but can be used in the treatment of hypertension. Coronary vasodilators, so they treat our angina or chest pain. They dilate the blood vessels by increase the oxygen supply. They are also called nitrates. So our nitroglycerin falls under this class. Isosorbide mononitrate is the other medication that typically is in this class, often called EMDR. a little bit easier to say. Our EMDR, or isosorbide, is our long-acting nitroglycerin. Nitroglycerin instructions have changed. Patients should take their first nitroglycerin pill under the tongue, sublingual, and wait 5 minutes. If their pain has not gone away, they should call 911 and they can take their second medication, their second pill of nitroglycerin, and they can take up to 3 doses in 15 minutes. So what has really changed is that they call 911 after taking that first pill that has not relieved the symptoms. Another important note for vasodilators is they should not be taken with PDE inhibitors such as Viagra. They have the same effect. They are vasodilators, so there can be a severe drop in blood pressure. And this is just a little cartoon with nitroglycerin showing that they vasodilate, which opens the blood vessels that may have that blockage that might be causing that angina or chest pain. There are several different types of nitroglycerin. There's the sublingual, which is the most common. It comes in tablets, and it also comes in a spray now. There's also the NitroBid patch that can be used. And I would say that our most common is the sublingual nitroglycerin tablets. Antilipidemic agents. So this is our cholesterol-lowering agents. Our first line of drugs that we use to treat high cholesterol are statin drugs. They inhibit the enzyme for cholesterol synthesis and increase LDL receptors. Therefore, it decreases our serum LDL levels. Common medications in this class, the first two are the most common, atorvastatin or Lipitor, which just went generic in 2014, so it is a lot cheaper for patients. Simvastatin or Zocor, also very common. Rosuvastatin or Crestor is a little bit higher powered. There's a higher response, however, is a lot more expensive for patients to purchase. Lovastatin and then Pravastatin. The common side effects of the statin drugs are elevated liver enzymes. So every time we are testing the cholesterol, we are oftentimes testing liver enzymes such as an ALT or an AST, serum blood level. And another common side effect is myalgias. Oftentimes, especially the simvastatin is mainly known for this. It can cause leg pains in patients, and patients will want to report that, and we will need to switch those medications as soon as possible. Antilipidemic agents, we also have bile acid sequestrants such as Questran or Welchol. These are not as commonly prescribed now. They used to be very popular before all of our options with statin drugs. They lower LDL levels by forming complexes with bile acid and thus causing the liver to make more bile acid for cholesterol in the blood. Niacin, which is over the counter, reduces hepatic synthesis of triglycerides and inhibits mobilization of free fatty acids. Niacin is a great vitamin to take if patients can tolerate the skin flushing and itchiness that is very common as a side effect. Instruct patients to take at night to help with these side effects, and patients can also take aspirin to reduce these symptoms. So try those couple of things before discontinuing the medication totally. Antilipidemic agents, we also have the fibrate classifications, which are used for high triglyceride levels. They inhibit the liver from producing VLDL. Also, they help in speeding up the removal of triglycerides from the blood. Most common is the fenofibrate, also called Tricor. We also see quite frequently the gemfibrozil or Lopid, which raises the HDL level also. We also have a cholesterol absorption inhibitor, which Zetia falls under this class. This is not widely prescribed after a study several years ago, which showed its minimal effectiveness. It's really rarely seen on medication lists now. You won't see this medication very commonly in the clinic. Fish oil. We have omega-3 fatty acids, which is over the counter. And then we also have Lovaza, which is a prescription strength fish oil. The common complaint with fish oil is the nasty fish aftertaste. It's important to take after large meals to minimize this fish aftertaste. Another trick to reduce that is to freeze or refrigerate the fish oil capsules and then take them. Sometimes this works, sometimes it doesn't with patients, but you can offer it as a suggestion. Antithrombotic agents interfere with the prevention, they interfere with or prevent thrombosis or blood coagulation. Anticoagulants thin the blood. Platelet inhibitors or antiplatelets aggregate platelets. They inhibit the clumping of platelets. This is particularly important when patients have stent placement with bare metal stents or drug-eluting stents. We want them on platelet inhibitors to prevent the clumping in those areas. Thrombolytics, which bust clots, are typically given when a patient is having a CVA. Anticoagulants prevent the formation of clots. They don't break down clots, they prevent the formation. They are divided into two groups. They are divided into oral and injectable kinds. Warfarin or Coumadin is the most common. It's used for long-term anticoagulation therapy and is monitored by serum levels. Some patients are tested weekly, some are tested monthly, and it really depends on their therapeutic level and how consistent they are. A PT-INR is the serum drug test that we draw. The normal levels are 2.0 to 3.0 if on Coumadin. Some conditions require patients' levels to be 2.5 to 3.5. Levels higher than 6 should be sent to the ER due to the high risk of bleeding. Patients can often be given a reversal agent. If they have drug levels higher than 6, they can be given vitamin K, which can reverse, or they can be given FFP, also known as fresh frozen plasma, to get that INR level down. Many interactions. There are a ton of interactions with warfarin. Antibiotics is one of the main ones. So most of our clinics in the central Wisconsin area have Coumadin clinics that monitor the patients and regulate their Coumadin and adjust their dosages. But if our physician in primary care places that patient on an antibiotic, we need to notify them because their INR levels are going to change. Their Coumadin, the effect of Coumadin is going to change. Patients must watch their vitamin K intake. We don't tell patients to stay away from vitamin K or foods that have vitamin K. We tell patients to be consistent with their vitamin K intake. That's very important. Be consistent. We don't want them to stay away from their leafy green vegetables because typically if they're a heart patient, they should be eating their leafy green vegetables more. So to be consistent and not take it away. Dosages can change for patients on a weekly basis. So a lot of times in your medication list, you will see as directed just because the dosage changes so frequently. Warfarin should be held prior to the most invasive procedures. So any type of surgery, most patients should be holding warfarin up to 1 to 2 weeks prior to the procedure to reduce bleeding risks. New oral anticoagulants, we have Pradaxa, Xarelto, and Eliquis. These medications should be stopped prior to invasive procedures also. However, they exit the system way faster. Usually they only need to be stopped 1 to 3 days prior to any procedures. There are fewer food and drug interactions with these new medications. However, they're more expensive because they are brand name only. And there is no reversal agent in a case of emergency. So if you get in a car accident and you are bleeding, there is no way to reverse that type of medication. Unlike Coumadin, which can be reversed with vitamin K or FFP. Heparin, there are 2 different types. There's standard and then there's low molecular weight heparins. They inhibit the action of the fibrin clot formation. It is not absorbed by the GI tract, so it either has to be given IV or subcutaneously. Many patients give it subcutaneously. Low molecular weight heparins are usually subcutaneous in the abdominal region. The most common medication is Lovenox. And when we are doing these medications, we will want a CBC and an APTT lab test to be done to monitor therapy. Lovenox is used for the prevention of DVT and hip and knee replacement surgeries, acute DVTs and pulmonary embolisms. It's also used in active STEMI, ST elevation MI patients. It causes lots of bruising in the abdominal area, so warn patients about that. The typical dose is 1 ml per kilogram, either once a day or twice a day, and it's up to your physician how they would like their patient treated, so it's important to ask them. This medication is expensive, so we don't want patients on this medication longer than they need to be. Many physicians will bridge, is the terminology they will use, bridge with Lovenox when patients are holding their Coumadin or just starting their Coumadin to prevent a clot formation. So when a patient needs to hold their Coumadin for surgery, we will sometimes bridge them with Lovenox. That's the terminology that we use in the clinic. Platelet inhibitor therapy. They inhibit the aggregation or clumping of platelets given to patients with a history of recent stroke, recent MI or stent placement, and then also peripheral vascular disease. Drugs in this class are Plavix or clopidogrel, Efficient or Brilinta. The main interaction with this drug class is our PPIs, or proton pump inhibitors. Patients on Plavix cannot take Prilosec. Aspirin also falls under this classification. So it's an anti-inflammatory, anti-pain, antipyretic, and it's also an antiplatelet aggregation medication. So a lot of times you will see our heart patients that either just had an MI or a stent. They will be put on Plavix and aspirin, so to help aggregate those platelets. It's kind of a continuum of therapy. Anemia treatments. Anemia can be due to acute blood loss from an accident or surgery, iron deficiency, or B12 deficiency. Iron supplements most commonly prescribed to cure anemia. So ferrous sulfate or Fesol, or slow Fe we also call it, are the oral types. Provide the body with iron needed for red blood cell development, energy, and O2 transportation. But iron does cause constipation, so it's important to tell our patients that they may need a stool softener while taking this. The other type of medication is iron dextran or Interferon, which is an IM or IV type therapy, usually IV, used in extreme depletion of red blood cells and hemoglobin levels. Regular labs such as a CBC and an iron panel should be drawn to monitor patients in their therapy. Megaloblastic anemia due to decreased erythrocyte formation, immaturity, or early destruction. Treatments our folic acid, which increases red blood cell, white blood cell, and platelet formation. B12, which replaces B12 in the body that normally doesn't absorb in the diet, is also used in pernicious anemia, and usually is given IM every day for 2 weeks and then once a month thereafter.